Welcome back to part 3. You now have a case of Leishmaniosis and you're wondering how to treat it.
So what treatment is recommended? So first of all, it's active Leishmaniosis. We want to be treating those that have active disease. So they've got evidence of skin changes, they've got evidence of joint disease, they've got evidence of cytopenias or significant proteinuриas that warrant treatment. We don't just treat because they have a positive antibody level or a positive PCR. And that's a really important thing to think about, because we do have some dogs coming in and they may never have had clinical disease, but they're on treatment. And those are the ones where we'd probably be saying, let's stop that treatment. In terms of what treatment looks like, and I've put the first line treatments on here, there are other treatment options that are available for dogs who we think either cannot tolerate these drugs or for whom that they've tried them but they seem to be refractory now. It is possible to get resistance to these drugs, but the prevalence of that is thought to be particularly low. So we tend to choose between one of 2 different induction agents, and we tend to give them for 4 to 6 weeks. The 2 agents that we have are meglumine antimoniate and miltefosine. Drug-wise, they are similar in cost to purchase the drugs. However, meglumine antimoniate is given by injection. It can be quite stingy and you can get injection site reactions. It is possible that it confers a slightly increased longer term response to it as compared to miltefosine. Miltefosine is administered in food. It's a liquid that's syringed onto food, tends to be relatively well tolerated, tends to result in a similar response rate in the shorter term, but there's concern that there's maybe increased risk of relapse with these 2 agents. These induction agents are given alongside a maintenance agent, allopurinol. If you don't give the induction agent alongside the maintenance agent, these dogs will relapse. After they've achieved remission, they will tend to relapse at around the 3 to 6 month mark, which is why we want to go in there with the maintenance agent. The allopurinol is started at the time of induction, but worth being aware that dogs can be on the allopurinol and can relapse even on it. And there's a risk of being on the allopurinol of xanthine urolithiasis. So we do have to bear that in mind and keep our eye out for it. Okay. In terms of other things that we do have to think about, if you remember to that little very paritic dog earlier on, if there's secondary bacterial infection, we'll be wanting to think about antimicrobials, particularly using some of our topical agents as well, if they're able to tolerate that, to reduce the infection at the level of the skin. Some of these dogs will also be heavily proteinuric as well, so we might need to think about treating those as well, particularly if they've got that significant proteinuria. Those are dogs that also will be wanting to add in the omega-3s to them. We'll be wanting to measure their blood pressure, and we'll be using the IRIS guidelines that talks about proteinuria and the management of glomerular disease and what drugs we reach for. So that is it's a secondary thing that we do also need to think about. We also need to think about their diet, both to support kidney function. A lot of dogs don't need to be on a kidney specific diet, but probably we're going to be wanting to alter their protein levels accordingly. We also need to think about reducing their risk of xanthine urolithiasis while they're receiving their allopurinol. So to do this, we want to encourage water intake, so by either giving them wet food or by adding water to their food such that it's soaked by the time they get to see it, so that they are actively eating the water to encourage bladder filling and then emptying. And some diets are better than others in terms of xanthine production. So going for a plant-based diet or a dairy-based diet tends to be better than being a high meat-based diet. And there's lots of diets out there now that are suitable for that, and we've guide them in our advice leaflet. In terms of getting hold of the medication, some of the drugs, so the meglumine antimoniate and miltefosine, are import-only veterinary drugs. The owners cannot get these with a prescription from their local pharmacy. You cannot get them from your local wholesaler. You need to jump through the hoops that are there for us to get a special import certificate from the VMD, and then you can supply that special import certificate to your importer to be able to get the medication. It's on a named patient basis. This does increase the cost, and it also delays you receiving that medication. We cannot treat these dogs as an emergency with these medications. It is a source of frustration to owners. It is a source of frustration to vets as well. Some of the medications are prescription only, but are available in the UK. These are agents such as allopurinol. You can provide owners with prescriptions for this, and also the adjunctive agent domperidone as well. We can use domperidone as an induction agent at high level. It is associated with some side effects, and we do prefer to use the others as induction agents where we can do. We don't use it first line. And we'll also sometimes use domperidone to reduce the risk of clinical leishmaniosis in dogs travelling to the continent. And we'll also sometimes use it to in dogs where we think that they're going to be higher risk of relapse when we come off all the medication. There are other medications that we will sometimes use in these patients. One of them is an adjunctive agent called Imprimune, which is a support medication. Owners can source this themselves online, and diet as well. Again, the diets the owners can source online as well. When we have a patient that is on treatment, we should be monitoring it. Now, during the induction period, so those first few days to the first week or so, what we're really going to be wanting to do is work out whether the dog is tolerating the induction agent. If they're on the meglumine antimoniae, we recommend doing a limited serum biochemistry and urinalysis to check for evidence of a transient tubulopathy that can occur in these cases that you might want to think about intervening on. But sometimes we do find these dogs hate the injections and owners just cannot administer them to complete the course. I've also had some dogs that just did not tolerate the miltefosine as well. They were vomiting, they were inappetent on it. And in some of these cases, we need to give them short courses of steroids to be able to allow them to get the induction course on board. Sometimes we have to think about what alternatives we can use as an induction agent. Immediately following induction, so at that 1 month period or approximately 1 month period, we should be looking at them again. We should be finding out whether their clinical concerns have improved or not. They should be much, much better, if not completely resolved. If they're not, we should be looking back at them and going, what did I miss? Was there something else happening there? And it could be that the drugs are just not working as well. As I said, we can get resistance. We'll be wanting to do some routine blood analysis at that point, so just heme and chem, and we're going to be wanting to see whether or not the previous cytopenias, the previous hypoglobulinemias, whether they're resolved or not. We'll also be wanting to perform urinalysis at that point. Again, we're looking to see for changes in proteinuria. If it was there before, has it improved? And we also want to look for evidence of crystalluria. Do we start to see xanthine crystals forming? And you do need to let your lab know that these patients are on allopurinol. Otherwise, they might mistake the crystals for ammonium biurate crystals, because that tends to be the default for crystals that look like that. We'll then be wanting to kind of monitor these dogs during that maintenance period, and it's not nailed down as to how often we do it. I tend to suggest at 4, 8 and 12 months following kind of the start of treatment, so that tends to be 3 months after finishing their induction period, and then 8 months total, 12 months total in that time frame. They should be free of their clinical signs. If they're not, we've either got ongoing problems, they tend to be at the highest stages of leishmania, or there's something else going on that we need to be thinking about and managing. Again, at those time points, we'll ideally be doing heme and chem, and actually after that 4-month period, we'll be start thinking about rechecking to see what their serology is doing. Ideally, we're going to be demonstrating their serology, tracking down on those antibody levels. And in an ideal situation, we want to see those antibody levels dropping down to 0, but that might just not be achievable. Some dogs maintain relatively high levels of antibodies. And then again, at those time points, we want to be checking their urine, looking for proteinuria, looking for crystalluria, and intervening as required. In terms of how these dogs do, most dogs will do fine. Most dogs, probably about 95% of them, will go into remission on the induction agent, particularly if they were in the earlier stages of leishmania, so stage 1 to 3, and where 1 is relatively mild skin lesions, where there's debate about whether we treat them or not, and 3 is through to where we're starting to see proteinuria happening in there. We've not got quite to the point of having really outrageous proteinuria or other kind of azotemia starting to kick in. But about 20% of dogs, regardless of the treatment that we use, will have a relapse. And they can do that even in the face of receiving allopurinol. So we do have to make owners aware that, yeah, their dog might be that 1 in 5 that might relapse again. And my feeling is that these dogs never clear the infection. If they've developed clinical leishmaniosis, they are always at risk of having leishmaniosis again at some point, and it may be years down the line that they may happen again. They just have to kind of bear that in mind. We do recommend, and this is a change to what has happened in previous years, stopping the allopurinol after 6 to 12 months. I prefer to think about thinking about it at the 8 to 12-month mark when you repeat that serology. And ideally, what we'd be wanting to demonstrate is completely normal clinical exam, completely kind of normal heme and chem, and ideally kind of low, if not negative, antibody levels at that point, by thinking about an earlier stop. If they're still positive at 12 months, again, I think ideally we'd be wanting to stop the allopurinol. As I said, it's not to say that these dogs won't relapse, and then there's risk if they're still high. There's a risk of drug resistance if we leave them on the allopurinol and it kind of comes out of remission again. But these are the dogs where I might start thinking about supporting their immune system, adding in intermittent domperidone, adding in Imprimune to them to try and support that immune response, to try and tip them in the way of getting those antibody levels down and stopping the disease from kind of coming back to being a problem. So that's definitely what I would do in those kind of persistently positive kind of cases. In those cases as well, particularly if they go on to relapse, I would be wanting to think, why did they relapse? What's happening with their immune system? My worry is that if they've relapsed once, there are going to be an increased risk of relapsing again, because inherently their immune system is not great. It's not able to hold the disease at bay. What can we do to support that? Is there something else we've missed, like a current infection that we do need to know about and address to try and maintain ourselves in remission? So kind of one slightly thorny question, what can happen to that dog? Can my other pets get the leishmania from them? And I think, unfortunately, it's yes. We have seen dog-to-dog transmission of leishmania in the UK, and the more dogs we have in the UK that have leishmaniosis, the more we are likely to see autonomous transmission within the UK. We don't know how it's transmitted. We don't know whether it's a parasite or mechanical close contact, but it's sensible in these cases to continue very good kind of management of any ectoparasites. So we don't want any parasites to be wanting to think about landing on these dogs, to even think about biting them, let alone anything else. I would much rather have a dog have a repellent tick collar on it than say get given a tablet every month to kill any ticks or flies that might go near it, just because there is a possibility if there's rapid transmission we might miss out on that. Okay, so again, we just need to be thinking about transmission in these kind of cases and how to limit the risk of that. I think it would also be sensible when you're handling these cases to wear gloves at least, and kind of you want to be obviously avoiding things like needle stick injuries as well. We don't want to be thinking about injecting the parasites into ourselves. It's also worth being aware it's not just leishmania. It's other gifts that do keep on giving. We can see autochthonous transmission between dogs, not just leash, but also various forms of Babesia, kind of Microti-like, Vogeli and Canis. And we've also seen autochthonous transmission of Ehrlichia canis as well, when it managed to get into a localized tick population. So when you do see cases that you're thinking, oh, this looks like kind of a vector-borne disease, but we don't have it in the UK, think again. With some of these, we are vectoring them, unfortunately. So thank you for listening to me. If you do have any questions, do look on our website, do have a look at the information leaflets we have available to us. Here is the QR code for the one for leishmania. But if you have a case that you've got clinical concerns about, that this paper doesn't answer your information, do drop us a message through the advice requests and we'll see what we can do to help you.